In this video, we're going to finish up our discussion of the cervical spine, and then we're going to move into both the thoracic and lumbar spine. So in this image, first off, you want to note the soft tissue. So notice that there's a fair amount of swelling up here in the upper cervical region, and then down here, you'll note a couple of osteophytes are present there. So that is an abnormality that's relatively frequently observed with the spine. You'll also notice that the intervertebral space here is, especially at this point, is significantly narrowed. And so this is an example of cervical spondylosis, which is spondylosis is just a definition of degenerative disc disease. And the soft tissue swelling you can see was explained in this patient by a fracture of the dens. So here you see that in a cross-sectional view, you get a really good view of that dens fracture. And then another is actually a bilateral fracture, so you can see the fractures on both sides of the odontoid process here in the middle. Here we have another image with an abnormality, so I'll give you a second here to look at it and see if you can identify what's going on with the patient. And so here we have another example of a teardrop fracture, which you can see on the C3 vertebra. And a zoomed in view, so you can see that teardrop fracture. Again, this is a type of avulsion fracture, in which case a muscle is pulling off a piece of the bone from the C3 vertebra. Now we have an example of what's known as Hangman's fracture through in this case, the pars interarticularis of C2. So the image or the drawing illustration on the left side shows you that the arrow that you see in between the anterior aspect of the soft tissue and the prevertebral tissue, and then the anterior body of the vertebra, that's going to be increased. That distance is increased due to the swelling that's going on there. You can also see a fracture of the pars, so coming down right through here. And then there's also this anterior dislocation of the C2 vertebra in this case. That's where you can see that if you follow the anterior borders of the cervical spine, this line should be continuous, as we discussed in a previous video. So you want to pay attention to that when you're assessing the cervical spine. And so again, in this case, you can see that there is anterior dislocation of C2, and so this is indicative of Hangman's fracture. The reason that this is called Hangman's fracture is it's typically caused by hyperextension that's caused when extreme force is placed usually right underneath the chin and causes this hyperextension of the head and neck. And so this is common with hanging. So this was first observed with judicial hangings back when that was common. They noted that the fracture of C2 was almost always initiated with hanging. So that's hence the name Hangman's fracture. Here we have another example of a Hangman fracture. So again, you can see that fracture there of C2. Here we have another example, and this one might be a little bit hard to appreciate, but in this case you can see here a fracture of the odontoid process. You can kind of see it coming up off of C2 right there. And then this is a CT view of or image from the same individual, where now you can hopefully better appreciate the fracture going across the dens. Here we have another example of degenerative disc disease or spondylosis, cervical spondylosis. So you can see here where the intervertebral disc space in between C5 and C6 is virtually absent in this patient, and so the surgeon has gone in and performed a fusion between the C5 and C6 vertebrae. So this is the lateral view post-operatively, and the image on the right shows the post-operative anterior or AP view so you can see the plate that's been put in with screws on either side. Now we're going to talk about the T-spine, so the thoracic spine. Remember that you should be able to see ribs coming off of each one of these vertebrae. So you can see T1 all the way down to T12. You can appreciate the pedicles on each one of these ribs. And remember, in the thoracic region, that the spinous processes are aimed inferiorly. So if you look at this vertebra as an example, you can make out the spinous process coming all the way down in an inferior direction. And so that's really relevant, not only from an imaging perspective, but also clinically when performing any sort of palpation. So you're trying to identify what level you're at, you're counting spinous processes. You want to keep in mind that, again, if we were to count down, so again, you have T1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. So let's say we're at the T11 vertebra. So we're palpating actually the T10 spinous process, but we're overlying the I guess this would actually technically be the T9 versus T10, since you can see this is T12. So, but in any event, just keep in mind that if you're palpating the spinous process in the thoracic region, you're actually one vertebral level lower than the spinous process that you're palpating. So again, this image here just shows that quite well. And again, you can see the ribs coming off of each one of these thoracic vertebrae. And then on the right-hand side of your screen, you can see a lateral view of the thoracic spine, so you can appreciate the curvature of the spine. Remember that the primary curvature of the spine is maintained in individuals or within the thoracic region of the spine. Here we have an illustration of the thoracic spine with the various features of the vertebrae. So once again, you can note that especially as you move down towards the mid region of the thoracic spine, you can appreciate the inferior orientation of the thoracic spinous processes. You can also see the superior and inferior articular processes forming the zygapophyseal joints, also known as facet joints. So remember that you'll be able to see those. You can see the inner spinous or the intervertebral space where the foramen, which is going to be where, remember that your spinal nerves are going to be emerging along with some arteries and veins as well. So that's the intervertebral foramen formed by the inferior vertebral notch above and the superior vertebral notch below, which you can better appreciate that here a little bit lower down. You also can see the joints formed by the ribs. So you can see each of these costal facets located at the superior and inferior margin of the posterior aspect of each of the thoracic vertebrae. And then also on the transverse processes, remember that you also have costal facets located there as well. So a significant condition that affects especially the thoracic spine more so than any other part of the spine is scoliosis. So scoliosis is defined as a lateral curvature that is greater than 10 degrees. So it's normal to have some degree of lateral curvature, especially in the thoracic region in any individual, but if it's greater than 10 degrees, that's when we classify it as scoliosis. And then from there, we can subclassify scoliosis based on whether the convexity is to the left or to the right. So if the convexity is to the left, it's called levoscoliosis. If it's to the right, we call it dextroscoliosis. So in this individual, you can see that the convexity is to the right side of the patient, and so this is an example of dextroscoliosis. There's also a measurement method that we can use in order to determine the way in which the patient is treated. So this is called the Cobb method for measurement of scoliosis. So what's the way that this is performed is you can see that a line is drawn along the plane of the upper thoracic vertebra that's sort of at the top point of the scoliotic curvature. And then you go down to the bottom one and draw a line off of the inferior margin of that vertebra. And then you connect each one of those with a 90 degree line coming off of either one, and then you measure the angle in between the two, and that's going to dictate how you treat the patient. So if it's less than 20 degrees between, if this angle here with the red dotted line, if that's less than 20, you just monitor the patient. If it's between about 25 and 40 degrees, that indicates bracing, or you give the patient a brace in order to help stabilize the spine. And then greater than 50 degrees usually indicates that surgery is indicated or needed. So this just, once again, gives you an illustration of the Cobb method. So you can see that the upper margin of one vertebra is used for one line, lower margin of another vertebra used for the other, where, again, following along the major part of the curvature. And then you can see the 90 degree lines drawn off of those, and then the angle between them indicates the degree of curvature. And so if it's 58 degrees in this case, that would indicate that surgery is needed. And then on the right here, you can see how the ribs are also affected by scoliosis, as will be the vertebrae themselves. So you can see one major issue is going to be that the rib on the on this side you can see is pushed posteriorly, which causes narrowing of the thoracic cage, and so that could potentially compress the lungs, especially, but also even the heart. It can be compressed, and so that's going to cause significant cardiopulmonary issues or potentially cause significant cardiopulmonary issues for the patient. So that's one of the reasons that surgically, or the reason that surgical intervention might be necessary with scoliosis is because of the fact that it's going to have a major effect on the function of the heart and lungs. On the vertebra itself, you can see how the spinous process is going to be deviated toward the concave side. So again, the convexity would be going towards this side. So in this case, the left-sided. So this would be levoscoliosis in this case. And then you can also see that the lamina typically is going to be thinner on the convex side here as well. One way that we treat scoliosis is by inserting a Harrington rod, again, to help stabilize the spine and keep it in a somewhat less scoliotic curve to it. And so a bone graft usually is also used with a Harrington rod as well, and it's placed along the concave side of the spine. So you can see this is the convex side over here, this is the concave side over here, and so that's where the Harrington rod has been placed. Here's another example of a Harrington rod that's been placed in an individual. So you can see how it's been attached above and below in order to help stabilize the scoliotic part of the spine. You also note that two Harrington rods are sometimes used. So although all the images that have been shown to you have just a single rod, it is not uncommon to use two rods. And the decision as to whether to use one or two usually comes down to the biomechanics of that individual patient's anatomy. Now we're going to spend a few minutes talking about different types of fractures. So we talked about a number of fractures that affect the cervical spine, but there's different types of fractures that tend to be more common in the thoracic and lumbar regions. And so I want to spend a little bit of time talking about each one of these. So first off, we have what's called a burst fracture. You can see an example of that in the upper left-hand corner, which typically will also involve part of the intervertebral disc, either above or below the vertebra that's been fractured. You can see an extension fracture here, which primarily is going to affect the intervertebral disc. We have a wedge compression injury over here, which is where usually the anterior aspect of the vertebra has been compressed and caused fracture of the bone in that region. Down here you can see an example of a dislocation of the spine. So this is where you can see the interspinous and intervertebral discs as well as the facet joint have all been disrupted as a result of this dislocation injury. And then finally we have rotational fracture and dislocation shown down here. So this is common with as the name suggests, over rotation of the spine. So looking at the wedge fracture, so this is typically occurs when a force is applied and it causes the anterior part of the vertebral body to crush. And so again, it causes the vertebra to look like a wedge shape because the anterior border has been of the vertebral body has been compressed or narrowed relative to the posterior aspect of the vertebral body. Here we have an illustration of a compression fracture. So you can see how basically this vertebra right here, this looks like this is in the lumbar region, has been compressed, and so that's causing that what we call the compression fracture. The image on the right here shows an example of a wedge fracture. So you'll note that the anterior margin of the vertebra is significantly narrowed relative to the posterior margin of the vertebral body. And so this is typically, although you don't see any the obvious evidence of a fracture in this person, you can see that there's a clear wedge shape to the vertebra, and so that's what indicates that a wedge fracture has likely occurred. All right, there's obviously a number of different types of variations on what these various compression fractures may look like. So again, you can see the different ways that a wedge fracture might appear. You have this biconcave appearance in some cases with compression fractures, and then you can see over here with the crush fractures where now you can see even the wedge where it might be reversed compared to what we typically see with the anterior margin of the vertebra being compressed with a wedge fracture, versus here you have a crush fracture where perhaps the posterior aspect might be what is compressed relative to the anterior aspect. All right, and so we oftentimes, when we're assessing wedge fractures, we will use a formula in order to calculate what the percent of the height of the anterior versus posterior aspect of a vertebra will appear. So you can see anteriorly here, we get a measurement, take a posterior measurement, and then we divide the anterior height by the posterior height, and that's what gives us the degree of difference between the two. And so that's one way that radiologists will potentially assess for a wedge fracture. Here we have another example where I'll give you a minute just to look at this image and see if you can identify what the problem may be. And so hopefully you identified L2 as the problematic vertebra in this case, and so you can see how it's been dislocated. It's clearly not well applied to the L3 vertebra and relative to L1 above it. All right, so now looking at a burst fracture. So remember that this is where the entire vertebral body is broken with a burst fracture. And so radiographically, typically a decrease in the overall vertebral height of 20% or more, or a decrease of at least 4 millimeters compared with baseline, is considered positive for a compression fracture. So that's typically some of the measurements that are used in order to assess whether a burst fracture is present or not. Here's an illustration of what a burst fracture looks like, so you can see how it basically just crushes the entire vertebral body from along its entire length. All right, so here we have an example of a burst fracture. So I'll give you a moment to see if you can identify which vertebra has been affected. And so hopefully you can see that this right here would be the sacrum, so you can see the sacral promontory, and then this would be L5, L4, and you'll notice that L4 has this clear fracture going across it. Here's another view of it where you can see on this lateral view very obvious evidence of this burst fracture going across the entire length of the vertebral body. And here's a cross-sectional CT of a burst fracture where, once again, you can see how the entire vertebra has clearly been fractured in this individual. So that's an example of another example of a burst fracture. Now moving down into the lumbar region, so you can see the lumbar spine. Remember that you have these very large vertebral bodies, and then relatively or quite broad spinous processes are going to be the defining features of the lumbar vertebrae. You can also see the superior and inferior articular processes are quite large in this region in order to help limit rotational movement in this region. You can see the facet joints or zygapophyseal joints, and then also note the costal processes here as well. All right, so here's an example of the lumbar spine. So you can see L1 count all the way down to L5, and then you can see the sacrum down here. So you can see the pedicles and then the adjoining spinous processes of these vertebrae. Now, this is another example with, on the left, we can see from Complete Anatomy, faded L2 vertebra, just to give you a sense of what you're looking at. So again, you can see the pedicles give these sort of eyeball-like appearance on the lateral aspect of the vertebral bodies, and then you can get a sense of where the lumbar vertebrae or spinous processes of the vertebrae are going to be located here as well. So you can see pedicles, and then of that same vertebra, this is going to be the spinous process of that right there. And then you can appreciate the facet joints here as well. So on this one, you can see here's a facet joint. Here would be another facet joint in between the superior and inferior articular processes. Here's a lateral view of the lumbar spine. So you can appreciate the intervertebral foramina right here where the spinal nerves are going to be emerging. You can see the L5-S1 junction right here as well. And then you can get a good sense of the curvature, the secondary curvature there of the lumbar spine, just like we see in the cervical spine. That's that lordotic curvature versus the kyphotic curvature that we see in the thoracic and sacral regions. So down here you can see the sacral kyphotic curvature. And then just zooming in so you can see that L5-S1 junction a little bit closer. That's an important region to make sure that you assess anytime that you're looking at the spine. And then here we have an oblique view of the lumbar spine. So this is going to be where you're able to appreciate, especially the pars interarticularis. So you can see the pars coming across right here. Here's the facet joints. You can see those between adjacent vertebrae. And then the pedicles are going to be located right here as well in line. So it kind of looks like this eyeball-like appearance that you see on these various vertebrae. And then you can also make out the transverse processes down here. And you can barely see them if you look really closely here in a more anterior direction. Here we have just another view of the lumbar spine in an oblique view. And so again, over here on the left, we have the complete anatomy view. So that's a good thing to play around with, to try to get a sense of how the vertebrae look on imaging. If you kind of rotate the spine around, fade out the vertebrae so they looks more like an image or a radiographic view, then you can, I think, get a better appreciation for where the various structures should be located on the lumbar vertebrae on imaging. So here you once again can see the zygapophyseal or facet joint, superior articular process, inferior articular process down here, and then the P represents the pedicle, and then the pars interarticularis indicated here by the white dotted line. And so one of the things that you want to be looking for when you're evaluating an oblique view of the lumbar spine is the Scotty dog sign. So again, we went through these various structures, but just to review, we have the transverse process outlined here. Then we have the superior and inferior, the superior articular process. Now we have the spinous process shown down here, the inferior articular process now outlined, as well as the lamina coming across right here, and then the pedicle representing the eye. And so now you can see how this kind of looks like a little Scotty dog. And so that's going to be an important structure to pay attention to when we're evaluating the lumbar spine, especially when looking for fractures of the pars interarticularis. So here we have a lateral view or oblique view of the lumbar spine, where hopefully you can make out the Scotty dog appearance quite well. Again, zooming in, so you can see those pedicles, facets. So again, superior and inferior articular processes, and then the pars interarticularis coming across right here. And in this case, you'll note, if you look at this pars versus this pars, notice that you don't see any defect here, but you do see a defect down in this image down here. And so that is a fracture of the pars interarticularis. So here we have just the same image with the various structures pointed out, and then there you see that pars defect. That's a fracture of the pars interarticularis. And so this is also known as spondylolysis at L4. And so again, this is the Scotty dog sign, which includes the radiolucent defect of the pars interarticularis. So it kind of looks like a collar on the Scotty dog. All right, here we have another view of a lumbar spine. And so a couple of the defects that you might note on this one are, first off, up here, you can see what's known as the winking owl sign, which is where you do not see the presence of the pedicle here. And so that usually indicates a metastatic disease, so where a tumor has metastasized to the spine, which is actually quite common in many individuals. And so when that occurs, oftentimes it affects the posterior aspect of the vertebral body and also the pedicles. And so when that happens, that causes this winking owl sign on a plain film. Down here, you can also see in this individual that they've experienced they have this lumbarization of the S1. And so that's where S1 is not completely fused with S2 as you would normally expect. And so we call this a transitional lumbosacral vertebrae, which is actually relatively common. It's found in about as many as 30% of individuals. And so here, this is just a Moore's view, a schematic showing what this looks like. So here you see the lumbarization of S1, which is what we're seeing in this patient right here. And then the converse of that is called sacralization of L5. And so that's going to be where part of L5 is either completely or partially fused with S1. And so in that case, this is another transitional lumbosacral vertebra, which again is found in about 4 to 30% of individuals. And so here you have the schematic of what that looks like. So sacralized L5, where you can see as on this side of the schematic, it's completely fused and partially fused on this side. So again, that's what causes that. And so here you see an example of that sacralization of L5.